substantial fat density. So this is a very typical appearance of a benign lesion. Here it is on ultrasound, smoothly marginated. It's very heterogeneous centrally with regions of fat epigenicity and glandular epigenicity. It's the typical appearance of a hamartoma, also known as a fibroadenomycoma, so a breast within a breast. They're present in 1% women and 5% of all benign breast tumours. They're slow-growing pseudotumours of fibrous, glandular and fatty tissue. They're usually asymptomatic, can be quite large in size and located anywhere in the breast. So as I've just shown on the mammogram, it's characteristic benign appearance of a fat-containing circumscribed mass. On ultrasound, the features do look like a breast within a breast. They don't need any biopsy unless there is an atypical feature such as suspicious microcalcification or an irregular margin. Sometimes they can look like circumscribed malignant tumours, such as Walden's tumours or breast sarcomas with larger. This is the next case of a benign breast tumour. I've just included the left MLO image here. You can see dip to the glandular tissue. You can see this lucent region that's close to the chest wall. Hasn't been entirely included on the mammogram and wasn't seen at all on the CC imaging. This is the appearance on ultrasound. It's fat density lesion close to the chest wall. It has some parallel epigenicities. It's smoothly marginated. The important thing to note about it is that you can actually see the pectoral muscle running deep to the lesion and separate from the roots of the chest wall. It has a very benign appearance and is typical of a lipoma, just a benign tumour of fat tissue, radiolucent on mammogram, rounded on ultrasound, isophoic or slightly hyperechoic to surrounding fat. So this next lesion here, this was a patient that presented with her right breast larger than left. This is her imaging. Initially, it was thought to be an adenoma, and she was left for 2 years for follow-up, and it had actually increased again in size. You can see again it's quite lucent, typical of fat, but there are some regions of it which are closer to glandular density. If you have a look here, you can see that this is like the pectoral muscle being pushed out. On ultrasound, it's obviously very large, but unlike the previous case, you can't see the deep aspect of the lesion. You cannot see the pectoral muscle with the chest wall. Had no internal vascularity. And it turned out to be a sarcoma, so that's the differential lipoma. If you really have to check that you can see the entire lesion. These are the T1 FATSAT, pre-contrast, post-contrast, and then the one T2 image. You can see that the lesion is actually inside the pectoral muscle there. It doesn't have a lot of internal enhancement, but it was biopsied as a liposarcoma. And this is the same patient 3 years later, and the lesion actually occurred, which does happen. This is the next benign breast tumour. This is a 45-year-old with a carcinoma in the right breast. It's quite obvious where this is. It's a mass in the upper front quadrant. It's quite dense compared to glandular tissue. It has a rather irregular margin, partly obscured. This is what it looked like on ultrasound. It's this entire region here with some glandular tissue components and some central hypoechoic components which have quite a distorted appearance. This is a case of pseudoangiomatous stromal. That's a proliferation of stromal-fibroblasts. It's associated with hormone exposure, in particular women on oral contraceptive pill or hormone replacement therapy. It can be asymptomatic or present as a palpable mass, may be tender. It may have slow or no growth. It's incidentally found on 23% of breast biopsies. It has no malignant potential but can coexist with other benign and malignant breast lesions. mammogram is oval or round. It's usually non-calcified mass with circumscribed margins, can be very large in size. It can also present as a focal asymmetry. An ultrasound has a highly variable appearance. Commonly it can be benign appearing oval, circumscribed or hypoechoic mass, or more like the last case I showed, however, there's a regular lesion with spectricity. It requires a core biopsy for diagnosis. If it's incidental, then there's no further workup. However, if it presents as an enlarging mass in a patient that's at high risk for malignancy, often in Australia we refer for surgical referral or consider excision because it can coexist with other lesions. This is not always the case. If you think that it's been adequately biopsied, then it's usually not necessary. So this is the same patient 2 years later, and hers actually got smaller. She also had some involution of the fibroglandular tissue. That was her previous imaging. This is another case of pseudoangiomatous stromal hyperplasia. Very difficult to see on the mammogram. There's a focal asymmetric density just lateral to the right nipple, best appreciated on the CC imaging. To be honest, we didn't pick it up on the mammograms. It wasn't until she went for the ultrasound. This is her tomosynthesis imaging. Again, it's very nondescript. And this is the ultrasound findings. She had this hypoechoic heterogeneous lesion with no shadowing. It's parallel. It could be mistaken for a fibrogranular complex cystic structure. This is a different patient, also with pseudoangiomatous stromal hyperplasia. This patient down here is pregnant and his mass was increasing rapidly in size, which is often the case. And this is the final breast tumor I'm going to discuss, the nipple adenoma. It's a benign epithelial proliferative lesion that involves a major duct orifice. It ends up with nipple swelling, erosion, redness, pain, and it can present as a mass. Sometimes it's asymptomatic. Most people are between the ages of 40 and 50. It's not seen on mammogram most of the time. On ultrasound, it's a circumscribed, solid hypervascular mass. And the concern is usually it has a similar presentation to Paget's disease of the nipple. Mammogram and ultrasound are performed to evaluate for any potential underlying malignancy. This is a case of a nipple adenoma. We have a look up here, there's a normal nipple, and adjacent to the nipple there's a hypoechoic mass, which is quite vascular. We've used some gel stand up here to evaluate the nipple wall. It requires a punch biopsy or an ultrasound guided biopsy for diagnosis. It does require complete surgical excision, as it can recur. So I'm just going to move on to some inflammatory breast conditions. These are benign breast conditions characterized by an inflammatory process. Both clinically and radiologically, they're very difficult to distinguish from inflammatory breast cancer. These include infectious mastitis, breast abscesses, granulomatous mastitis, lymphocytic mastitis, and periareolar mastitis. So this is the first case, a 31-year-old with right breast pain and peritoneum. This is her mammogram. You can see here there is an asymmetric density in the lower outer quadrant of the right breast. And there's some subtle skin thickening in the inferior breast. There's nothing else we need to see in the mammogram. This was her ultrasound. She had a few regions of hypoechoic ductal tissue. This was the palpable lump that she got, which was hypoechoic tissue with some marked shadowing, very ill-defined. There's no discrete collection seen. This was the skin thickening and generalized edema within the breast tissue. And this was the right axillary lymph node, which had a cortical thickness of 4 millimeters, usually was 3 millimeters of colour. So this was a case of infectious mastitis. They can be divided into lactational and non-lactational mastitis. It's associated with smoking, diabetes, and surgery. The most common organisms are Staphylococcus aureus and multi-resistant Staphylococcus aureus. Treatment as it known as antibiotics and ultrasound guided drainage, which may need to be repeated. If the symptoms persist after adequate treatment with appropriate antibiotics, ultrasound guided core biopsy is usually recommended. And in lactating patients, as we previously mentioned, ultrasound is the first method for evaluation. However, following adequate course of antibiotics, mammography is still indicated in lactating patients when there is a clinical suspicion for malignancy, or those where a prolonged clinical course has occurred without an actual fluid collection. As you can imagine, it has quite a suspicious appearance. So usually on mammography, you can see some significant the asymmetric density, can have an architectural distortion and enlarged lymph nodes. The ultrasound appearance is quite variable. The current primary system usually hypervascular. You can have multiple hyperlipid collections like this with little fluid component, all the way to quite circumscribed breast abscesses. This is a very typical appearing breast abscess with peripheral vascularity. You can see it's nearly erupting through the skin. Interestingly, inflammatory breast cancer can also respond to antibiotic therapy initially. So this is another case of infectious mastitis. You can see this whole lateral part of this breast has increased density. There's multiple abdominal lymph nodes. This is a 48-year-old who presented in the same manner with a red, swollen left breast. This one was inflammatory breast cancer. There is this asymmetric density, some lymph nodes, and a lot of skin thickening. And this is another patient with inflammatory breast cancer, very similar to the infectious mastitis I showed earlier, large density occupying most of the right breast, multiple abdominal lymph nodes, and skin thickening. On ultrasound, it's very suspicious appearing, hyperlipid with a lot of shadow. So this is the next inflammatory breast condition. This is a 35-year-old female with painful left breast, already been on 2 weeks of antibiotics and not improving. You can see there is quite a lot of difference between her right and her left breast. Again, this is a global increase in density, and as you can see, there's some very subtle increased density in the retromarrow fat, which is a typical appearance of edema in the breast. This is what it looked like on ultrasound. She had multiple regions of hyperlipoic tissue with increased vascularity within her glandular tissue. There was one region deep to the nipple that had more of a fluid component to it. And this is a case of granulomatous mastitis. That's a non-infective inflammatory breast condition. It's characterized by lobulocentric non-permeable granulomas, typically in Paris women. It's often unilateral, as in the last case, can be found anywhere in the breast, but doesn't typically involve the nipple. On mammogram, it's a focal or global asymmetry with an irregular indistinct mass or masses and some associated distortion. On ultrasound, you can see a lot of irregular mass or masses with ill-defined hyperlipoic tissue, edema, fluid collection, and dilated ducts. The end result of granulomatous mastitis is often fat necrosis, abscess formation, or fibrosis. It can be seen in a wide variety of age group, from the late teens to 40-year-olds. It's usually diagnosed within 5 years of pregnancy. 50% resolve without any treatment. Others progress with antibiotics and can reoccur. Needs a core biopsy for diagnosis, and the treatment is steroid therapy and methotrexate for resistant cases. So, this is another case. This is a 32-year-old female with a right breast carcinoma. She She has quite typical breasts to look at on their own. They are patchy glandular tissue. They're already asymmetric. So I don't think that you can discreetly see the asymmetric density it is here, just like the clinical. This is what she looked like on ultrasound. So her normal left breast with normal glandular tissue and fat, and then her right breast, she had this quite thickened glandular tissue with marked shadowing without a discrete lesion seen. This is the typical appearance for this next condition, lymphocytic mastopathy. It's also known as diabetic mastopathy. Usually seen in 30 to 50-year-olds. It presents with a large, painless hard mass, which is indistinguishable from cancer. It's seen with long-standing insulin-dependent diabetes, autoimmune disorders such as Hashimoto's thyroiditis, Sjogren's syndrome, and systemic lupus. It's often multicentric and bilateral. As shown on that mammogram, it's an ill-defined mass or symmetry. It's often not seen. On ultrasound, it can be a hypoechoic irregular mass with posterior shadowing or an area of shadowing without a discrete mass. Often has increased vascularity. You also need a core biopsy for diagnosis of this case. It's self-limiting disease that does not require treatment, but has frequent occurrences. This is another case of lymphocytic mastopathy in a 50-year-old. Again, you can see there's an asymmetric density in her upper quadrant of the left breast. This is what it looked like on ultrasound. Quite upper tissue with some posterior shadowing. And this is another inflammatory breast condition. This is plasma cell or perioral mastitis. This is a really common condition. It's chronic with periductal inflammation and diffuse plasma cell infiltrate around ducts and lobules. It can present with pain, tenderness, and liver discharge. Often the overlying skin becomes discolored and firm, which makes it clinically difficult to distinguish from cancer. On average, it occurs 4 years after ceasing lactation in 20 to 40-year-old women. Rectal hyperplasia may be present and it may be atypical. And it has characteristic large robot calcifications on mammogram. So this is the typical appearance of it. I guess in some ways it can resemble DCIS if it's just in a small area, but it tends to be symmetric, bilateral, or quite broad involving all different areas of the breast with a typical appearance of projecting towards the liver. It's typically thicker, longer, and more uniformly dense than DCIS, and very common. So just the take-home messages from that many benign lesions have characteristic features which require us to do one leg out, particularly in cartomas and cartomas, quite rare lesions, and others can mimic malignancy. Again, you need to make sure that the radiological findings are concurrent with the pathology, otherwise you might need to consider biopsying or excisions. And just be careful of lesions that may be in the chest wall rather than in the breast, like the lipoma and the liposarcoma. Also, you have to be aware of palpable and new masses in middle-aged patients, even if they look benign and the patient says that it's new, it's worth a biopsy. And considering short-term follow-up or biopsy for breast abscesses or mastitis that does not respond to therapy, also in high risk for older patients.